handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hey everyone, my name is Dr. Carl Lavillo. You can call me Dr. Carl. For today, we will be having the part 2 of organ system integration of the cardiovascular system. So let's start. So, what we will do here, no, yung part 2, it consists of pathology, microbiology, and pharmacology. So what I did was, I did not set apart the sections for patho, micro, and pharma. Kasi, as we discussed the pathology of the specific diseases included in the lecture, what I did was, I incorporated the discussion for micro and pharma already. So, ginawa ko yun kasi para ma-maintain ninyo sa memory nyo yung context ng disease, because I think if we set them apart and discuss them separately, you will tend to forget the context or background of the pathology of the disease we are discussing. So I think it's better if we discuss the pathology and then yung micro and then yung pharma ng disease na yon, and then move on to the next. Okay, that's what we will do for this session. So we start with hypertensive vascular disease. There are different kinds. We have primary or essential hypertension. We also have secondary hypertension and malignant hypertension. No, so pag sinabing primary or essential hypertension, there's no identifiable cause. It is seen in 90 to 95% of cases. And then for secondary, ang etiology niya ay dahil sa renal, endocrine, or neurologic causes. But among these, yung sa renal or yung tinatawag na primary renal disease, it is the most common etiology of secondary hypertension. We also have malignant hypertension. It occurs when more than 200 over 120 ang BP. It is a severe form of hypertension. It can be either primary or secondary. Now, in terms of pathogenesis, sa essential, yung mga pwedeng maging causes nito, pwedeng genetic factors or insufficient renal sodium excretion, pwede ring vasoconstrictive influences or environmental factors such as obesity, smoking, or physical inactivity. In terms of secondary, di ba sabi natin yun nga, dahil siya sa mga primary renal disease, endocrine, or neurologic. In terms of renal, pwedeng dahil sa renal artery stenosis, kasi di ba pag may renal artery stenosis, nagdi-decrease yung blood flow into the afferent arteriole, papunta dun sa glomerulus. So what happens is, dahil may decreased perfusion dun sa afferent arteriole, nasa-sense yun ng juxtaglomerular cells, and they will secrete renin, and then yung end product, ma-convert yung angiotensin-O-gen to angiotensin-1 and then angiotensin-2. And then yung angiotensin-2 naman yung magpapa-increase ng, kasi di ba may vasoconstrictive effects ang angiotensin-2. So, ang mangyayari ay eventually magkaroon ng hypertension. So, that's how renal artery stenosis causes secondary hypertension. We also have other etiologic factors, mga endocrine. It can be Conn syndrome or dito nagkakaroon ng increased aldosterone. So, di ba, aldosterone increases sodium reabsorption, and where sodium goes, water follows. So, mag-increase din yung blood volume kasi dadami yung water na nare-reabsorb sa tubular lumen or sa renal tubule. So, mag-increase yung intravascular volume. So, mag-increase yung BP. And then sa Cushing syndrome naman, yung increased glucocorticoids naman yung primary reason kung ba't nag-increase yung peripheral resistance. Sa pheochromocytoma, nag-increase yung catecholamine, so nag-increase yung peripheral resistance. And then sa thyrotoxicosis, the increase in thyroid hormones causes increased cardiac output kasi nag-increase yung heart rate. Kasi di ba, one of the signs of thyrotoxicosis is tachycardia, di ba? So sa vascular pathology naman ng hypertension, what we see, the common feature is luminal narrowing. And what you will see is arteriolosclerosis. There are two types, no? So pag sinabi nating arteriolosclerosis, ang sinasabi dyan is, ang definition nun is hardening of the arteries with arterial wall thickening and loss of elasticity. So, ibig sabihin, nagiging stiff in a way yung arteries, no? So, there are two types of arteriolosclerosis. We have hyaline and hyperplastic. So, pag sinabing hyperplastic, commonly associated with diabetes mellitus and essential hypertension. So, what you will see is homogeneous pink hyaline thickening. As opposed sa hyperplastic, ang buzz, so sa ano kasi, sa pato, madalas, no, dapat na-memorize mo, nakakabisado mo yung mga buzz words or buzz phrases. Kasi sila yung madalas na tinatanong sa mga board exams. So yung hyperplastic arteriolosclerosis, ang kanyang morphology is concentric laminated thickening, described as onion skinning or onion skin lesions. So, dahil siya sa proliferation of smooth muscle cells. So, dito mo rin makikita sa hyperplastic arteriolosclerosis, yung fibrinoid deposition and vessel wall necrosis. And it happens in patients with malignant hypertension. So, okay. So, di ba kanina nag-pathology tayo? Now, we go to pharmacology. So, in-incorporate ko na siya. So, yung drugs natin for hypertension, there are several choices to choose from. No, itong mga to. Pero syempre, hindi sila kasi dekahon na kahit ano pwede mong gamitin sa kahit anong sakit. Di ba? So, it depends on the clinical context and yung sakit ng patient. So, for example, in a patient with hypertension and heart failure, hindi tayo gumagamit ng beta blockers if yung patient na yun na may hypertension and may heart failure comes to the ER with decompensated heart failure. Yung mga patients kasi na may decompensated heart failure, commonly, mababa yung BP nila. So, since ang beta blockers, it inhibits beta-1 receptors na nag-increase and when stimulated, increases heart rate and contractility. So, in patients na mababa yung BP dahil may decompensated heart failure, pag nagbigay ka ng beta blockers, dahil mababa na ngayon kanilang BP and yung kanilang contractility, cardiac contractility, nagbigay ka pa ng beta blockers, mas malalo mong ipupush yung patient into decompensated heart failure. And pag hindi mo na-resolve yun, eventually it will lead to cardiogenic shock. And then, another patient population with special consideration, kung ano yung ibibigay mong antihypertensives is patients na may diabetes mellitus and hypertension. Instead of selecting beta blockers or diuretics or vasodilators as antihypertensives, in patients with diabetes mellitus, you can select, and hypertension, you can select instead ACEs and ARBs kasi they have been shown in studies to be protective against DM nephropathy kasi they decrease albuminuria, no? Na toxic kasi sa mga renal tubules. So, if you give ACEs and ARBs, you decrease the albuminuria and you protect the patient against the progression ng DM nephropathy niya. And then, in patients with diabetes mellitus, na kung for example, nagtitake ng insulin, you can opt to not give them, or you should be cautious in giving them beta blockers. Kasi di ba, in patients nagtitake ng insulin, they are prone to hypoglycemic symptoms if hindi sila kumain, tapos for example, ng breakfast, pero nagturok sila ng insulin, tapos hindi sila kumain. They can precipitate hypoglycemia. Now, signs and symptoms of hyperglycemia is sympathetic nervous system activation. So, they will feel tremors, and then tremors, tas parang diaphoresis, tachycardia. Now, if you give beta blockers, mabablock niya yung mga symptoms na yun, and the patient will not recognize na nag-hypoglycemia na siya. So, madedelay yung kanyang pag-seek ng help para ma-relieve yung kanyang hypoglycemia. Madedelay yung pag-seek niya ng source of glucose para ma-resolve yung hypoglycemia. Until such time na sobrang bababa na ng sugar and mawala na yung serum glucose, and then maging comatose na siya, no? Mawala na ng malay. So you have to be cautious in giving beta blockers in patients with diabetes mellitus. And then in patients with asthma naman and hypertension, you should avoid non-selective beta blockers para ma-prevent mo yung beta-2 receptor-induced bronchoconstriction. Kasi pag sinabi non-selective beta blockers, ini-inhibit nila yung beta-1 and beta-2 receptors. Pag sinabing selective beta blockers, ini-inhibit na lang, ang ibinablock lang nila or ini-inhibit lang nila is yung beta-1 receptors. Di ba yung beta-1 receptors? Sa heart, it increases heart rate and cardiac contractility. Ang beta-2 naman, ang ginagawa nila, they, pag na-activate ang beta-2, it can promote bronchodilation. Now, if you give non-selective beta blockers, pag binalock mo yung cardiac, yung beta-1, yes, it will reduce heart rate, no? And at the same time, it will also block beta-2 receptors kasi non-selective nga eh. So, what happens is, from bronchodilation, magiging bronchoconstriction. So, ma-aggravate mo yung problem niya sa airways kasi yun nga, may asthma nga siya. So, ano ba yung mga non-selective and selective beta blockers? Pag sinabing, so, ang tandaan ninyo, yung selective beta blockers, sila yung, ang pangalan ay A to M, M or mic. Okay? Most of them, but not all of them, no? Kasi, for example, so, ano yung mga example ng selective antagonists or selective beta blockers? So, ang example niyan is atenolol, betaxolol, bisoprolol, esmolol, metoprolol. So, lahat sila from letter A ng alphabet up to M or mic. Diba? So, sila yung mga selective beta blockers. We also have non-selective beta blockers. So, pag sabi non-selective beta blockers, they mostly go from, yung names nila, they mostly go from N or November, N to Z ng alphabet. So, ano yung mga example ng non-selective beta blockers? Yung mga nadolol, pindolol, propranolol, and timolol. So, lahat sila, nagsisimula yung name nila sa letters from N or November, N to Z. Okay, so sila yung non-selective beta blockers. Ulitin ko, selective beta blockers, they are yung mga pangalan na nagsisimula sa from A to M, okay, or mic, or yung first half of the alphabet. So, atenolol, betaxolol, bisoprolol, esmolol, metoprolol, sila yung mga selective beta blockers. And another population na may special consideration in giving antihypertensives is in patients na pregnant. Meron lang mga select na antihypertensives na pwede mo ibigay in patients with hypertension. So, ito lang sila, nifedipine, methyldopa, labetalol, and hydralazine. Kasi yung iba, they can cause problems dun sa baby. For example, nagbigay ka ng ASI or ARB sa patient na pregnant, it can cause fetal na renal malformations dun sa baby. So, contraindicated ng ASI ARBs sa mga pregnant. Okay? Ito lang commonly yung binibigay natin. So, that's for hypertension. We go to atherosclerosis. So, it is atherosclerosis is essential in the pathogenesis of coronary, cerebral, and peripheral vascular disease. And the diagnostic lesion sa atherosclerosis is atheroma or atheromatous plaque. Risk factors are divided into non-modifiable and modifiable risk factors. So this is hyperlipidemia, hypertension, cigarette smoking, diabetes mellitus, and inflammation. Yung non-modifiable, hindi mo sila sa word itself is non-modifiable. So, wala kang magagawa sa genetic abnormalities mo, sa increasing age, being male, and family history. Dito, pwede mo pa itong makontrol. Okay? Pwede kong magbigay ng gamot, you can stop smoking, you can give antihypertensives or this meds for dyslipidemia. Okay? So, yung atherogenesis ng atherosclerosis, no, how it forms. So, nagsisimula tayo sa normal artery. So, magsimula tayo sa normal artery. So, this is the lumen, the endothelium. Smooth muscle, itong makapal na pink na to. Okay? So, yung unang nangyayari is endothelial dysfunction. So, pag sinabing endothelial dysfunction, nagkakaroon ng damage dun sa endothelium. Okay? So, yung two important causes of endothelial injury leading to damaged endothelium ay hypercholesterolemia and hemodynamic disturbances. So, ano ibig sabihin ng hemodynamic disturbances? So, for example, ay kunwari yung mga arteries na, di ba maraming branches yung arteries, usually nagfo-form ang mga atherosclerotic plaques dun sa mga areas of na merong turbulent na blood flow. So, saan may turbulent blood flow? Doon sa mga kung saan nagfo-fork, kuwari may isang malaking artery, tapos biglang magfo-fork siya doon. So, from initially laminar na blood flow, dahil nga nagdumaan siya doon sa fork o kumbaga nag-part ways yung dalawang, nag-branch out siya into two branches, yung artery. So, nagkakaroon ng turbulent blood flow doon, and yung turbulence na yun, it can damage yung endothelium. So, dahil doon sa damage endothelium, macrophages will go to that site. And if there's high levels of LDL or LDL cholesterol or low density lipoprotein cholesterol in the blood, yung macrophage na yon magiging LDL-laden macrophages. And then yung LDL-laden macrophages na yon, they will become foam cells, no? So they will become foam cells and eventually magiging fatty streak. So from endothelial dysfunction, magkakaroon ng fatty streak formation. Okay, yun yung pinagsama-samang foam cells and LDL-laden macrophages, mga oxidized na LDLs na nasa macrophage. And then eventually, yung fatty streak na yun na may foam cell and LDL-laden macrophages, magmamigrate na doon yung smooth muscles. So kanina, di ba, walang migration ng smooth muscles dito? Di ba? Kita nyo dito, no? Eventually dito, yung smooth muscles na nasa ilalim will migrate there, karoon ng smooth muscle migration, and eventually magiging siyang fibrous plaque. So magkaroon ng fibrous plaque formation, and eventually magiging ganito na, as you can see here, no? Morphology, nung diniscuss natin kanina ng fatty streak. So, small, flat, yellow macules sila na elongated, and they contain lipid-filled foamy macrophages. Diba? And eventually, from this fatty streak, magiging siyang fibrous plaque or atheromatous plaque na merong fibrous cap and lipid core. So, as you can see, ito yung fibrous plaque niya, yung nandito sa taas, and yung lipid core is itong dilaw na to. Okay? And, so yun nga, ang kinocontain ng atheromatous plaques na yun ay smooth muscles, macrophages, and T cells. Yung lipid-laden na, LDL-laden na macrophages. And then smooth muscles na nag-migrate, no? And there is a presence of neovascularization na nasa periphery ng atherosclerotic plaque. Now, yung most common sites of involvement ng atherosclerosis ay sa may lower abdominal aorta, particularly below the renal arteries and iliac arteries. The second most common sites of involvement are coronary arteries, and yung least common ay circle of Willis. Okay? So this is just a magnified view of yung ating atherosclerotic plaque kanina. We have the fibrous cap, and then yung necrotic center or yung lipid core, and then nandito na yung smooth muscle sa ilalim. And then may mga smooth muscles din tayo na nandun sa fibrous cap. Ito, no? Nasa taas ng lipid core. So ano yung mga possible na pathologic changes sa mga atherosclerotic plaque? It can result into a rupture, ulceration, or erosion, or it can also magkaroon ng hemorrhage. It can also lead to atheroembolism or aneurysm formation. So pag sinabing rupture, ulceration, or erosion, so ang nangyayari, no? Sa loob kasi ng atherosclerotic plaque na yun, may mga thrombogenic substances. Now, pag yung na-erode or nag-rupture dahil manipis yung fibrous cap, pag manipis yun, pwede mag-rupture yung atherosclerotic plaque, exposing the blood to thrombogenic substances. Now, pag na-expose yung blood na merong platelets and coagulation factors, na-expose siya sa thrombogenic substances na nasa loob ng lipid core, it can form a thrombosis. So, from initially, ito yung blood vessel, tapos ito yung atherosclerotic plaque, nag-rupture siya dito, initially ganito lang yung occluded area ng blood vessel, di ba? Tapos dito dumadalo yung blood. So pag nag-rupture yan, tapos na-expose yung blood sa thrombogenic substances, magkakaroon ng thrombus dito. So papatong siya dyan yung thrombus. So magkakaroon ng partial occlusion dito. So dito na lang dadalo yung dugo, dito na lang. Pero kasi ito occluded na to. Pag lumala yung thrombosis na yon, from partial occlusion, it can at worst lead to total occlusion, leading to yung mga ACS natin. Pwedeng end-stage ACS, which is dalawa, di ba? Unstable angina and end-STEMI, or STEMI, ST elevation MI. Another pathologic change that can happen in an atherosclerotic plaque is hemorrhage into that plaque. So kasi di ba sabi natin kanina may neovascularization sa may peripheries ng atherosclerotic plaque. So it could lead to intraplaque hemorrhage with plaque expansion and eventually rupture ulit, which ganun pa rin yung magiging mechanism. Another thing is atheroembolism. Yung thrombus na nag-form dito sa taas na to, it can mag-embolize into, for example, sa pulmonary vessels, or it can also lead to embolism into the distal na branches of the arteries, okay, as microemboli. It can also lead to aneurysm formation, which is yung atherosclerosis nagko-cause ng weakening of the wall, leading to aneurysm. So there are two consequences of atherosclerotic disease. It can lead to stenosis or acute plaque change. Ito yung na-discuss natin kanina, yung acute plaque change na can lead to rupture, erosion, ulceration, or hemorrhage. And this is the most dangerous consequence kasi pag nangyari yun nga, acutely pwedeng, dahil acute yung mga events, from initially ito lang yung occlusion, acutely pwede siyang lumaki. And from partial to total occlusion, it can happen in a matter of minutes, and dun nagsisimula yung chest pain that will lead to ACS or yung end-stage ACS or STEMI. Can also lead, so that's acute plaque change. Meron din tayong more gradual na process in atherosclerotic stenosis. It could lead to gradual occlusion of the vessel lumen. And eventually, if that gradual occlusion reaches a critical threshold, yung tinatawag na critical stenosis, around 70 to 75% of occlusion ng total area of the blood vessel, it could lead to critical stenosis, and this is where tissue ischemia starts. So this is just a summary of yung progression ng atherosclerotic plaque and how it leads to sudden events and then yung eventual outcomes nila. Okay? So sa atherosclerotic plaques, there are three generalities. Number one, the thickness of the fibrous cap. Di ba ito yung fibrous cap natin? Okay, this one. And dito, manipis na fibrous cap. Yung thickness ng fibrous cap na yun is directly proportional to the stability of that atherosclerotic plaque. Meaning, the thicker the fibrous cap, the less likely it would result to rupture. And the thinner the fibrous cap, more likely siya mag-rupture. Okay? Number two generality sa mga atherosclerotic plaque is size of lipid core. Okay? So, it is inversely proportional to stability, meaning the thicker the lipid core, the less stable it is. So, tingnan mo to. Thin yung fibrous cap, makapal yung lipid core as compared dito. So, kaya siya yung nag-lead to plaque rupture. Okay? Pero hindi naman lahat ng ganito yung characteristic is plaque rupture. No? It can also lead to erosion lang and thrombosis. No? And the third generality is the degree of inflammation. It is inversely proportional to stability. So, ibig sabihin, the more inflammation present sa may atherosclerotic plaque, the more prone it will be to plaque rupture. No? So, ito yung na-discuss natin kanina. It starts with a normal blood vessel, and then secondly, magiging fatty streak, and then magkakaroon ng intimal thickening. Eventually, magkakaroon ng atherosclerotic plaque. Kasi magkakaroon ng formation of fibrous cap and then lipid core. And then, pag nagkaroon ng plaque rupture, tapos hindi mo na-resolve yun, hindi mo siya nadala sa hospital, yun na ACS na, and then eventually magkakaroon ng sudden cardiac death. So, ano yung treatment natin for atherosclerosis? So, pharmacology na tayo. For atherosclerosis, meron tayong mga lipid-lowering drugs. So, these are the drugs used for dyslipidemia. So dahil ang isa sa, 'di ba, yung mahalaga nating kailangan to decrease, kailangan nating i-resolve in patients with atherosclerosis is yung LDL cholesterol, 'di ba? Yun yung bad cholesterol. Gusto natin siyang babaan para konti na lang yung available for formation of atherosclerotic plaques. Kailangan mababa yung LDL cholesterol para mababa yung available na LDL para na mababa yung available LDL na magpo-form ng mga atherosclerotic plaques. Okay? So how do we lower the LDL? Meron tayong apat na medications. We have statins, resins, ezetimibe, and niacin. So, di-discuss natin yung mechanism of action nila. So, sa statins, ini-inhibit niya yung enzyme na HMG-CoA reductase. So, ang ginagawa nun, with inhibition of the HMG-CoA reductase, it will inhibit the conversion of HMG-CoA to mevalonate. So, ang mevalonate, cholesterol precursor siya. So, if you inhibit yung enzyme na yan, bababa yung precursor, so magdi-decrease yung cholesterol precursor, and magdi-decrease din eventually yung production or synthesis of LDL cholesterol. Okay? So, pag nagbigay ka ng HMG-CoA reductase inhibitors, magdi-decrease yung intrahepatic cholesterol kasi nabawasan nga yung cholesterol precursor, di ba? So, magdi-decrease yung intrahepatic cholesterol. And pag nag-decrease yung intrahepatic cholesterol, ang compensatory response ng liver is to increase the number of high-affinity LDL receptors. Kasi wala nang cholesterol sa liver, so hahanap na siya sa periphery, sa blood. So, mag-i-increase niya yung LDL receptors ng liver, and ang gagawin ng liver, pag marami na siyang LDL receptors na high-affinity, i-clear niya yung blood of the LDL and VLDL remnants. Gagamitin niya yung LDL and yung VLDL remnants na nasa blood, yun yung gagamitin niya na source niya ng cholesterol, source ng liver ng cholesterol. So, bababa yung LDL na nasa blood. Okay? So, nagbibigay tayo, mainly nagbibigay tayo nun for dyslipidemia, no? And other diseases that we can give HMG-CoA reductase inhibitors, yung mga patients na may coronary artery disease or yung may mga ACS, yung acute coronary syndromes, diba? NST, ACS, or STEMI. So, actually, ang binibigay natin sa patients na may ACS and STEMI or STEMI is mga high-dose statins. So, pag sinabing high-dose statins, dalawa lang. Meron kasing iba't ibang statins, di ba? Lovastatin, pravastatin, simvastatin. Pero may dalawa lang na statin na may high dose. Dalawa lang. Atorvastatin, na ang dose ay 40 to 80 mg, and rosuvastatin, na ang dose ay 20 to 40 mg. Sila lang yung mga statins na may high dose na na may high doses, no? Sila lang yung considered na gano'n. Yung others, hindi sila high dose statins. Mga lang yan, mga low intensity or moderate intensity statins. So, hindi mo sila pwedeng gamitin sa mga patients na may ACS. Yung second na medication for dyslipidemia na nagpapababa ng LDL cholesterol is bile acid binding resins. So, ano naman mechanism nito? So, normally, may mga bile acids tayo na sinisecrete from the liver, papunta sa gut, lumen, and ginagamit sa pag-digest ng mga fats, no? Dietary fats. And eventually, yung bile acids na yung magiging urobilinogen. And eventually, marireabsorb sila sa may bandang ileum. So, from the ileum, so 20% of the urobilinogen, 80% of the urobilinogen will get excreted via the stool. So, yun yung nagpapakulay sa dumi. And 20% of the urobilinogen will be reabsorbed through the ileum na tinatawag natin na enterohepatic circulation. 90% of the 20% will go to the liver and 10% will go to the kidney ng urobilinogen. Okay? So, ang ginagawa ng bile acid binding resins, binabind nila yung bile acids and pine-prevent nila yung intestinal reabsorption sa ileum. So, parang pine-prevent nila yung enterohepatic circulation. So, pag ginawa niya yon, so pag pinrevent niya yung bile acids na may cholesterol, pag binind ng bile acid binding resins yung bile acids na may cholesterol and pinrevent niya yung intestinal reabsorption nito via the enterohepatic circulation, mababawasan yung cholesterol pool. So what happens is, mababawasan na naman yung cholesterol na nasa liver or yung hepatic cholesterol. Parang medyo kamukha ng HMG-CoA reductase inhibitors, di ba? So mangyayari, dahil bawas na yung hepatic cholesterol and dahil bawas na yung dahil 'di ba usually nga yung urobilinogen ma-reabsorb via the enterohepatic circulation and mababalik yung bile acids na ginamit doon sa pag-digest ng mga fat ng mga dietary lipids, 'di ba? So, pag yung bile acid binding resins, binind yung bile acids, masisecrete sila, ma-excrete sila through the stool. So, ibig sabihin, mababawasan yung bile acids na i-recycle ng liver na may laman na cholesterol. So, ang mangyayari, no, yung ibang cholesterol na nasa liver, gagamitin ng liver to synthesize new bile acids kasi wala na siya walang bumalik kay liver through the enterohepatic circulation kasi nga binind ni bile acid, di ba? So babalik so dahil walang bumalik sa kanyang bile acid, sabi ni liver, gagawa na lang ako ng bagong bile acids with the hepatic cholesterol na meron ako, no? So meaning madadivert yung hepatic cholesterol into synthesizing new bile acids. So, ang mangyayari, yung cholesterol na sana ay ginamit ni liver sa ibang bagay, igagamitin sa paggawa ng new bile acids. Tapos, bababa yung total cholesterol ng liver. So, anong gagawin ni liver? Dahil pinanggawa niya ng cholesterol, pinanggawa niya ng bile acids yung mga cholesterol niya. Dahil bawas na yung hepatic cholesterol ni liver, ang gagawin niya, i-increase niya ulit yung high affinity LDL receptors para kukuha ulit siya ng LDL from the blood to clear the blood of LDL na cholesterol. Okay, so parang medyo kamukha siya ng HMG-CoA reductase inhibitors na nag-i-increase ng high affinity LDL receptors para mag-increase yung LDL removal from the blood. Okay? So bababa ulit yung LDL na nasa blood. Now another medication for cholesterol to decrease the cholesterol in the blood, yung LDL, is ezetimibe. So, actually, simple lang naman ang ginagawa ng ezetimibe to prevent cholesterol absorption at the small intestine brush border. Okay? So, ano yung ini-inhibit ni ezetimibe na transporter? Yung NPC1L1. So, NPC1L1 transporter, siya yung nagme-mediate ng uptake ng cholesterol from the gut lumen papunta sa blood. So, if you inhibit that, nape-prevent yung cholesterol absorption. Okay? Niacin. So, maraming mechanisms of actions ang niacin. So, ito yung the following. It inhibits lipolysis by hormone-sensitive lipase. So, ano ba yung hormone-sensitive lipase? So, ang hormone-sensitive lipase, na-activate siya by catecholamines. And catecholamines, they get secreted during periods of stressful situations. So, pag na-secrete pag na-activate yung hormone-sensitive lipase, it will promote lipolysis and the release of free fatty acids from adipose tissue, no? So, ang ginagawa ni niacin, ini-inhibit niya lipolysis na to para ini-inhibit niya yung lipolysis by hormone-sensitive lipase para hindi mag-release yung adipose tissue ng mga free fatty acids. Okay? So, bababa yung LDL sa body, sa blood. So, yung net effect ng niacin is to reduce LDL cholesterol, triglycerides, and VLDL, and to increase HDL level. So, sa mga nabanggit natin na medications kanina, wala pa tayong nabanggit na nakakapagpa-increase ng HDL, di ba? Niacin pa lang yun. So, ang mahalaga na board exam na naman concept in terms of niacin is is that it causes cutaneous flushing. Okay? So, may iba ring drugs na nagkakos ng cutaneous flushing. We have vancomycin, adenosine, niacin, and calcium channel blockers. Now, tandaan ninyo, sa niacin, di ba nagkakos siya ng cutaneous flushing? Diba? So, ang mechanism of yung facial flushing in patients na nagtitake ng niacin, you have to know that yung kanilang facial flushing is prostaglandin mediated and not histamine mediated. So, bakit mahalaga yung malaman? Kasi, pag nalaman mo na yung facial flushing is mediated by prostaglandin, you will know na ang treatment for that facial flushing na caused by niacin is NSAIDs. Kasi di ba ang mechanism of action ng NSAIDs is to inhibit cyclooxygenase, di ba? And cyclooxygenase yung enzyme na nagko-convert ng arachidonic acid into the different prostaglandins. So if you give NSAIDs sa patients na may nagtitake ng niacin and nagkaroon sila ng flush face, ma-treat mo yung facial flushing na yun. Ngayon, kunwari, so you have to know that. You have to know that mechanism. Kasi that will tell you na dapat hindi ka magbigay ng antihistamines sa mga patients na may facial flushing na dahil sa niacin. Okay? So this is just a very nice illustration of the summary of yung mga dyslipidemics na na-discuss natin kanina and their mechanism of action. So this is from USMLE First Aid for the USMLE Step 1 na book. So ito yung na-discuss natin kanina, di ba? Na yung HMG-CoA. Meron siyang enzyme na HMG-CoA reductase that converts HMG-CoA into mevalonate, and mevalonate will eventually become cholesterol, di ba? So if you inhibit HMG-CoA reductase, mape-prevent mo yung pag-form ng mevalonate into cholesterol, and dahil nababawasan na yung intrahepatic cholesterol, ang gagawin ni liver, i-increase niya yung mga high affinity LDL receptors, and yung mga high affinity LDL receptors na yun magko-collect or magagad or parang kukunin nila yung mga LDL na nasa blood. Okay, so ito, tulad nito, kinuha niya, papunta dun sa liver through the LDL receptor. Okay? Now, yung isa nating diniscuss kanina ay ezetimibe. It inhibits cholesterol absorption, di ba? NPC1L1. It inhibits cholesterol absorption from the intestinal lumen papuntang enterocyte. Another thing is yung ating bile acids, ini-inhibit natin yung reabsorption nito na babalik siya sa enterohepatic circulation, di ba? Pinaprevent natin yung reabsorption ng bile acids para ma-excrete natin sila sa stool. Another is ini-inhibit natin yung lipolysis ng adipose tissue para that will eventually lead to the release of free fatty acids into the blood. At ang nag-i-inhibit ng lipolysis nito is niacin. Next, we go to aneurysms and dissection. Okay, meron tayong, so ang aneurysms, they are defined as localized abnormal dilatation of the blood or the heart. And there are two types. You can be true or false na aneurysm. And there are different forms of aneurysm. So we have true aneurysm, saccular or fusiform. And we also have false aneurysm. So, yung risk factors ng aneurysm and ng dissection, medyo magkaparehas sila. No? So, medyo hindi mo kaya talagang i-separate totally itong dalawang disease processes ito ng aneurysm and dissection. Kasi yung risk factor for aneurysm is hypertension and ganun din sa dissection. So, ang dissection naman, the blood tunnels in between the layers of the walls. As you can see here, ito yung layers of the wall, ito yung muscular layer, and then ito naman yung tunica intima. So, sa dissection, nag-extravasate yung blood, so, pumupunta siya sa gitna ng intima endomedia. And the most common cause ng dissection is intimal tear. So, pag may butas dun sa intima, dun talaga papasok yung blood. Okay? And yung dissection, ito yung dinidivide natin into different classifications. Meron tayong DeBakey and Stanford. Meron tayong DeBakey 1, 2, 3 and Stanford Type A and Type B. So, para matandaan ninyo kung sino yung may 1, 2, 3 and yung may A and B, tandaan lang ninyo yung pag pinronounce nyo sila, ilan yung kanilang syllables. Diba? DeBakey, so DeBakey 1, 2, 3. And we also have Stanford A and B. Okay? Tandaan din ninyo, ang DeBakey 1 ay parang nag-drawing ka ng 1. 1. Okay, ganito ang drawing mo ng 1, di ba? So, ibig sabihin, ang DeBakey 1, it involves the whole of the aorta. Okay, from the ascending to the descending at saka abdominal aorta. So, pag sinabi naman DeBakey 2, it only involves the ascending aorta. And pag sinabi natin ng DeBakey 3, it only involves yung after ng left subclavian vein, below the left subclavian vein. So, paano nyo naman tatandaan yung type A and type B? Pag sabihin, type A, it only involves yung, it always involves yung ascending aorta. So, type A is ascending aorta. Kasi, meron tayong dalawa, ascending aorta and yung other parts of the aorta, and ito naman is ascending aorta din. So, those are parehas na type A. Pag sinabi naman na type B, pag sinabing type B, no, parang 3, no? Parang 3, no? Type, DeBakey 3, tapos type B, okay? Pag sinabing type B na Stanford, below the left subclavian artery. Okay? Below. Meron tayong iba't ibang pathogenesis of aortic dissection and aneurysm. So, pwedeng for intrinsic quality of the vessel wall from vascular Ehlers-Danlos syndrome, which is ang cause ay defective type 3 collagen. Pwede rin na abnormalities in TGF-beta signaling. Ang example nito is in patients with the Marfan syndrome na may defective fibrillin. So, glycoprotein yung fibrillin na yan na nagsisequester ng TGF-beta. And if that happens, nagdi-decrease yung extracellular matrix content and vascular integrity. We also have abnormalities in collagen remodeling, leading to increased collagen breakdown and loss of smooth muscle cells. So, other clinical manifestations. So, for the clinical manifestations of aortic aneurysm and dissection, in general, they can present with a mass or any other symptom na pertaining to mass effect ng palpable pulsating abdominal mass and other specific clinical manifestations ay depende dun sa structure na nako-compress. For example, kung malapit yung aneurysm sa bone, it can present with bone pain or it can also present as hemorrhage or cardiovascular collapse pag nag-rupture yung aneurysm. So, meron tayong dalawang aortic aneurysm. It can be thoracic in terms of kung ano naapektuhan. It could be thoracic or abdominal aortic aneurysm. Pag sinabing thoracic aortic aneurysm, it's associated with cystic medial degeneration. So, yung cystic medial degeneration, more commonly associated siya sa ascending aortic aneurysm. Pag descending thoracic aortic aneurysm, more commonly associated siya with atherosclerosis. And yung cystic medial degeneration na yun, na associated with ascending thoracic aneurysm, is associated with Marfan syndrome. Ang treatment, okay, we go to pharma ng thoracic aortic aneurysm. Ang treatment is beta blockers. Recommended siya for those with aortic root dilatation to reduce the rate of further expansion. So, kailangan mo i-read kasi, di ba, habang nag-expand yung aneurysm, nagwa-widen yung lumen ng aorta. And together with the widening of the aortic lumen, nagwa-widen din yung aortic valve. So, pag nag-widen yung aortic valve, hindi siya masyadong opposed on diastole, no? On diastole, yung blood na nasa aorta pwedeng bumalik into the left ventricle, leading to aortic insufficiency or aortic regurgitation. So, we also have abdominal aortic aneurysm. It is usually associated with atherosclerosis, parang descending thoracic aorta, di ba? And may present as a palpable pulsatile abdominal mass na most often is infrarenal. Treatment naman dito dahil associated siya with atherosclerosis is statins. Di ba nabanggit natin kanina? Sa thoracic aortic aneurysm, walang statins na minention. But kung yung patient naman na yun ay yung patient profile niya is pasok as fit siya sa criteria for starting statins, mag-start ka na rin ng statins dun sa mga patients na may thoracic aortic aneurysm. Now, in patients with abdominal aortic aneurysm, we start statins. Now, di ba sabi natin beta blockers ang treatment sa thoracic aortic aneurysm? Sa abdominal aortic aneurysm, yung mga beta blockers, they have not been proven to reduce the rate of aneurysm growth. So, ang other treatment for abdominal aortic aneurysm is operative repair. Now, aortic dissection naman, ang patient profiles ito, karaniwan ay mga 40 to 60-year-old males na may hypertension, 90% of them. Pero pag ang naapektuhan ng aortic dissection is a young patient with connective tissue defects, most likely may Marfan syndrome yun. Clinical manifestation nila ay sudden excruciating anterior chest pain radiating to the back. Di ba marami tayong differentials sa mga patients na may anterior chest pain, pero yung pag nag-radiate yan to the back, malaki yung chance na aortic dissection yung most likely na initial impression mo. Other clinical manifestations of aortic dissection is markedly unequal yung BP sa both arms. So, okay? So, kaya nga sa mga patients na may chest pain, you have to check yung BP sa both arms kasi pwedeng aortic dissection yun. So, bakit nagkaroon ng unequal BP sa both arms? Kasi kunwari, yung aortic dissection, pag nag-propagate siya until, for example, hanggang sa may right brachiocephalic trunk. Di ba yung right brachiocephalic trunk, nagbabranch out siya into right common carotid artery and right subclavian artery. So, pag nag-propagate yung aortic dissection up to that, doon sa opening ng right brachiocephalic artery, magkakaroon ng occlusion doon. And pag nagkaroon ng occlusion doon, babagsak yung BP sa may right arm. And hindi siya maging equal sa left arm. Okay? So, in a patient presenting with chest pain and radiating to the back, tas unequal yung BP in both arms, mas magiging convinced ka. So, magkakaroon ka ng more clinical evidence to support the diagnosis or the initial impression of aortic dissection. Sa chest x-ray, it can show mediastinal widening naman. So, ang initial lesion ng aortic dissection is intimal tear. Most common site is ascending aorta. Okay? And meron ding in traumatic chest injury cases, pwedeng after the origin of the chest arch vessels at the ligamentum arteriosum. Histologically, what you will see is medial degeneration as well, pero walang inflammation. Okay? In terms of treatment, you have to reduce contractility and systemic arterial pressure, and medical therapy should be initiated as soon as the diagnosis is considered. Now, mahalaga yung classification kung anong klaseng dissection siya, kung Stanford type A and Stanford type B, kasi mag-iiba yung management. So, in patients with Stanford type A, emergent or surgical correction. And in patients with Stanford type B, medical therapy naman in the form of IV beta blockers, sodium nitroprusside to further lower the SBP to less than equal 120. You can also use non-dihydropyridine na mga calcium channel blockers in the form of verapamil and diazem, and IV na ACE inhibitor and nalaprilat. But vasodilators are contraindicated. Okay? Bawal ang vasodilators kahit mataas ang BP. Kasi it can increase hydraulic shear stress and propagate the dissection. Next, we go to myocardial infarction. So, a myocardial infarction, death of cardiac muscle due to prolonged ischemia. And sa mga patients with myocardial infarction, there's loss of contractility of the myocardium within 1 to 2 minutes of the onset of severe ischemia, and eventually magkakaroon ng irreversible injury if hindi mo ma-resolve yun after 20 to 30 minutes. The earliest detectable feature, so lagi itong tinatanong, okay, ano yan, buzz phrase yan sa pathology. Earliest detectable feature of myocyte necrosis is sarcolemmal membrane disruption. So there are different patterns of myocardial infarction. It could be transmural or subendocardial and multifocal microinfarct. So pag sinabing transmural, buong wall, no, from here hanggang sa labas. Now, nangyayari yan pag nagkaroon ng epicardial vessel occlusion and wala kang nagawang intervention. So, kumbaga, buong muscle, buong thickness ng muscle ang nagkaroon ng infarction kasi hindi mo siya nadala kunwari sa ospital, gano'n. And they would present sa ECG as ST elevation. Now, ang subendocardial ischemia naman, nangyayari yan pag may acute plaque change, nagkaroon ng lysis of thrombus, and then the blood flow gets restored. Sabihin, hindi naging totally occluded yung blood vessel. So, hindi naging transmural. Hindi buong thickness ng myocardium na nagkaroon ng infarct. Subendocardial lang. Ito lang. Okay? And sa ECG, it would present as ST depression. So, the most common coronary artery occluded, coronary artery that is occluded is the left anterior descending artery, which is a branch of the LMCA or the left main coronary artery. Okay? So the LAD or the left anterior descending artery supplies the anterior wall of the LV near the apex, anterior portion of ventricular septum in the apex. The right coronary artery supplies the inferior wall. Okay? And the left circumflex naman supplies the lateral wall of the LV. Sa gross morphology, grossly, no, wala ka pa makikitang changes pag less than 12 hours pa lang. Okay? After the 12 hours, from 12 to 24 hours, magkakaroon ng congestion and extravasated blood. And then on the 3rd and 7th day, magkakaroon ng granulation tissue, and after several weeks, magkakaroon ng fibrous scar. But microscopically, no, sa gross morphology, di ba wala pa makikita pag 12 hours? However, pag microscopic morphology, 6 to 12 hours pa lang, magkakaroon ka na ng coagulative necrosis. So that's microscopically. And then on the 1st to 3rd day, acute inflammation by PMNs muna. Okay, PMNs yung mauna dun sa site of infarct. And then on the 3rd and 7th day, macrophages na. 7th and 10th day, granulation tissue, and then eventually healing by fibrosis. So this is just a table na makikita ninyo sa inyong handouts. I will just leave that to you to read. Okay? So this is just, ang pinapakita lang dito is yung gross features and yung light microscope findings sa myocardial infarction. Now, in order to diagnose patients with ACS, no, it depends on these three things: presentation, ECG, and troponin. Diba? So sa presentation, kung so it exists in a spectrum. No? So kung low ang likelihood na ACS yung patient if yung chest pain niya is hindi diffuse, meaning localized lang. So pag dito lang, medyo tumataas yung likelihood. Pero if diffuse yung chest pain, tapos may radiation pa sa both arms, most likely yan ay case of ACS. And then on ECG, nag-increase yung likelihood of being ACS pag may changes. For example, kung ST depression or ST elevation. Tapos, maliban sa ECG, is serum troponin. Kung negative, low likelihood of ACS. And then kung positive ito, and then may ST depression, most likely that would be STEMI. Samantalang pag may ST depression, pero may negative in troponin, that would be unstable angina. Okay? Na syempre, kung ST elevation and mataas yung troponin, obviously that's STEMI. So, in terms of cardiac biomarkers, we have cardiac troponins and CKMB. So, it matters a lot na alam niyo yung time of detection and return to normal. Kasi parehas lang naman yung peak nila. So, actually, medyo close lang naman yung time of detection ng cardiac troponins. Mauna lang siya ng isang oras, 3 to 12 hours, and then CKMB is 48 hours. They peak at the same time, but yung kanilang return to normal is mas mabilis mag-return to normal yung CKMB. So, mahalagang knowledge to, no? Kasi, for example, in patients na nag-re-MI or re-myocardial infarction, kuwari nag-MI sila today, and then the next week nag-MI ulit sila. After 7 days, nag-MI ulit sila. Ang kukunin mo na cardiac biomarker by that time, para masabi mo na baka nga nag-re-MI siya or nag-ACL, nag-myocardial infarction ulit siya, ang kukunin mong biomarker is CKMB. Bakit? Kasi by that time, on the 7th day, yung CKMB, nag-return na sa normal. So, ibig sabihin, pag nag-present ulit yung chest pain yung patient after 7 days, nag-present ulit with chest pain, at kumuha ka ng CKMB, by that time, returned na to normal yung CKMB levels. So, pag tumaas yun, baka nga nag-ACS ulit siya or nag-re-myocardial infarction or re-MI. As opposed sa cardiac troponins, nag-MI siya ngayon, nag-MI siya ngayon, and then after a week, after 7 days, nag-chest pain ulit siya. Tapos pagtingin mo, pagpunta niya sa ER, tapos nagpakuha ka ng troponin, mataas pa rin yun. Okay? Kasi hindi naman siya pa bumabalik sa normal. Okay? So, ibig sabihin, baka mag-falsely positive yung makita mo sa cardiac troponins. So, CKMB yung mas may value para malaman natin kung nag-re-MI yung patient. Okay? So, ito yung mga consequences of myocardial infarction. Marami sila. So, we have contractile dysfunction, which can lead to cardiogenic shock, papillary muscle dysfunction, which can lead to post-ischemic mitral regurgitation, myocardial rupture, arrhythmias, pericarditis, chamber dilation, mural thrombus, ventricular aneurysm, and progressive late heart failure. So in terms of treatment, so pharmacology na ulit tayo, we have antiplatelet therapy. Ito yung mga doses nila. Usually, makikita mo sa clinics is aspirin and clopidogrel. We have antiplatelet therapy, and we also have anticoagulant. So, antiplatelet, anticoagulant. And then, yung mga antihypertensives natin, mga ACEs, ARBs, beta blockers. And then, we also have statin. Di ba nabanggit natin kanina? Meron tayong dalawa lang na statin na may high dose. Yung kanilang form, we have Ator na 40 to 80 and Rosu na 20 to 40. So, those are the only two high-dose statins. And we also give lactulose and proton pump inhibitors. Nagbibigay tayo ng lactulose para hindi sila umire. Pag dumudumi sila, hindi sila mag-Valsalva maneuver. Kasi pag nag-Valsalva maneuver sila, mag-i-increase yung magkaroon ng positive intrathoracic pressure. Kasi you're expiring against a closed glottis, di ba, pag Valsalva maneuver. So, nag-i-increase yung intrathoracic pressure, so leading to decreased venous return and decreased preload and decreased stroke volume, decreasing the cardiac output. So, pag nag-decrease yung cardiac output, you're decreasing the blood supply to an already to an area na may already low na blood supply kasi nga may occlusion. So, parang babawasan mo palalo, no? So, you also give proton pump inhibitors kasi kailangan natin i-prevent yung possible na UGIB or upper GI bleeding kasi ang dami natin binibigay na bleeders, yung mga antiplatelet, yung pampadugo, antiplatelet, and anticoagulants. So, this is the mechanism of action of aspirin, no? Aspirin inhibits coxsackie-oxygenase para ma-prevent natin na magkaroon ng thromboxane A2. Thromboxane A2 promotes platelet aggregation kasi ayaw natin magkaroon ng platelet aggregation kasi nga, di ba nga, ang pathophysiology ng ACS is plaque rupture, acute plaque rupture, na expose yung blood to thrombogenic substances, di ba? And so, nagkakaroon ng thrombosis and nagkakaroon ng partial to total occlusion. So, we have to prevent platelet aggregation. So, isa pa is clopidogrel. So, ang ginagawa naman ito is to inhibit ADP P2Y12 receptor. Ito naman, ang ginagawa nito is for platelet activation. So, also inhibit platelet activation. So, another is yung sinabi natin na LMWH or enoxaparin. Ang inhibit naman ito is thrombin. Ang thrombin is it converts fibrinogen to fibrin, and from fibrin, mag-form na siya ng fibrin mesh to stabilize the platelet plug. So, kailangan natin inhibit yun para hindi maging malakas or maging fully formed yung thrombus na nag-form dun sa above the atherosclerotic plaque. Okay? Para hindi na worsen yung occlusion. Okay, we go to cardiomyopathy. So, there are two primary groups of cardiomyopathies. We have primary and secondary. Pag sinabing primary, it can be genetic or acquired. Pag sinabing secondary, it's a consequence of systemic disease in cases of hemochromatosis or amyloidosis. We have three patterns of cardiomyopathy. We have dilated, which is the most common, hypertrophic, and restrictive. So, tandaan niyo yung EF na pag mababa yung EF, that would be dilated, and kung mataas, it can be either hypertrophic or restrictive. And ang dilated cardiomyopathy or DCM, ito yung ang dysfunction niya ay systolic, diastolic naman sa hypertrophic and restrictive. Ang mahalaga malaman ninyo dito sa cardiomyopathy is kung ano yung mga common causes. So, naka-bold naman sila. So, we have alcohol, myocarditis, hemochromatosis, and doxorubicin. So, tandaan niyo, according to Harrison, alcohol is the most common toxin implicated in chronic DCM. However, chemotherapy naman are the most common drugs implicated in toxic cardiomyopathy. So, pag ang tanong is most common toxin, that would be alcohol, na implicated in chronic DCM. And pag ang tanong naman is what is the most common drug implicated in toxic cardiomyopathy, which also leads to DCM, that would be chemotherapy. So, yung mga chemotherapy na nagkakos ng DCM, we have doxorubicin. And another one is isang gamot na ginagamit for breast cancer patients, that would be trastuzumab. Okay? So, hypertrophic cardiomyopathy, ang mahalagang buzz phrases dito is there's a genetic mutation in the beta-myosin heavy chain. Okay, so pag nabanggit nyo yan, pag nabanggit nyo sa question stem, hypertrophic cardiomyopathy agad. Another na makikita mo sa hypertrophic cardiomyopathy or HOCM or HCM, makikita mo is asymmetrical septal hypertrophy with a banana-like configuration of the LV cavity. Okay, so HCM yan. Now, pag ang causes naman ng DCM is amyloidosis or endomyocardial fibrosis, that would be RCM. Okay? So this is just a representation of yung mga major forms of cardiomyopathy. So the DCM, HCM, and RCM. So makita mo, enlarge yung mga chambers sa DCM, and sa hypertrophic naman, hindi man ganun kalaki yung chambers, pero malaki yung muscle, no? Yung myocardium. And restrictive cardiomyopathy, stiff naman yung kanilang walls. Next is myocarditis. So, the etiology is either infectious or non-infectious. Kung viral, it's Coxsackie-B, which is the most common cause. Kung helminthic naman, it's T. spiralis or Trichinella spiralis, which is the most common helminthic cause. And pwede rin mag-cause ng myocarditis yung T. cruzi or the etiologic agent of Chagas disease. No? T. cruzi is Trypanosoma cruzi. So, dito tayo magkakaroon ng microbiology. Kanina kasi wala tayong microbiology na na-discuss, no? So, kasi di ba nasabi natin, the most common cause of viral myocarditis is Coxsackie-B. So, saan ba nabibilong ang Coxsackie-B na viruses? They belong to the picornavirus family. And yung mga viruses na that belong to the picornavirus family is remembered by the mnemonic perch. We have poliovirus, echovirus, rhinovirus, yung cause ng common cold, Coxsackie viruses, and HAV, or yung Hep A virus. They can cause aseptic meningitis, herp angina, hand, foot, and mouth disease, pericarditis, and myocarditis. Okay? So, Coxsackie virus belongs to the picornavirus family. We also have Trichinella spiralis, which is a helminth. The transmission is through undercooked meat, especially pork. They can cause the symptoms of fever, vomiting, nausea, periorbital edema, and myalgia. Ang tawag din is trichinosis. And they can be treated with bendazoles in the form of albendazole, mebendazole, mga ganun. Trypanosoma cruzi. It causes Chagas disease. Now, transmission nito is when the triatom insect or yung kissing bug, it bites and defecates. Tandaan nyo, bites and defecates around the mouth or the eyes. Okay? So, ibig sabihin, hindi natatransmit yung T. cruzi through the bite. Ang ginagawa, it is transmitted through the feces ng bug. So, nagkakaroon ng fecal transmission into the bite site. Okay? So, ibig sabihin, dumudumi siya doon sa saan siya kumagat, and doon natatransmit yung Trypanosoma cruzi. Meron din tayong kilalang sign sa sa Chagas disease. That would be Romania sign, which is unilateral periorbital swelling, which is characteristic of the acute stage. Morphology of myocarditis. So, it depends on kung ano yung cause. If it's hypersensitivity myocarditis, you will see perivascular infiltrates composed of lymphocytes, macrophages, and eosinophils kasi nga hypersensitivity myocarditis, diba? And then, kung giant cell myocarditis, it would makikita mo histologically is multinucleated giant cells. Okay? And then, kung Chagas disease myocarditis, you will see trypanosomes naman. Okay? Now, cardiac tumors. Well, cardiac tumors are not that common. Um, primary malignant tumors are rare. Pero pag ang tinanong sa patho is what is the most common primary cardiac tumor in adults, that would be myxomas. But if the question is in children, that would be rhabdomyoma. Okay? So there are different common sources of metastasis to the heart. So pwedeng lung, breast, melanomas, leukemias, or lymphomas. No, ang myxoma ay most commonly yung location niya is in the atria, more commonly sa left atrium than the right atrium, and it is associated with several syndromes, no? It could be associated with the Carney complex and the McCune-Albright syndrome. Now, ang presentation ng myxoma is yung tinatawag na ball valve obstruction. So what happens is, for example, nakahiga yung patient, ito yung mitral valve orifice, ito yung left atrium kung saan nandito yung myxoma. Kung nakahiga yung pasyente, ito yung myxoma, ito yung mitral valve orifice. Pag nakahiga yung pasyente, hindi naman siya dumidikit doon. Pero pag nag-upright siya, by gravity, bababa yung myxoma into the mitral valve orifice. Hinaharangan niya yung diastolic blood volume na pupunta sa left ventricle, leading to decreased stroke volume and decreased cardiac output. So, pero pag humiga ulit siya, mawawala ulit yung obstruction kasi pag humiga ulit siya, babalik ulit yung myxoma and mawawala yung harang niya into the mitral valve orifice. So, yung tinatawag ng ball valve obstruction. So, usually single lang siya, and gross morphology, you will see soft translucent papillary villus lesions with gelatinous appearance. Histologically, what you will see is myxoma cells embedded within acid mucopolysaccharide matrix. Na kung common yung myxoma sa atria, common naman yung rhabdomyoma, which is the most common primary cardiac tumor in children, sa ventricles. And it is associated with tuberous sclerosis na complex. So ano ba yung mga ibang findings natin sa tuberous sclerosis? So ano mga buzz phrases dun, buzzwords, yung mga adenoma sebaceum sa ilong, mga papillar lesions sa ilong ng patient na may tuberous sclerosis, shagreen patch, no? Parang rough na patch ng skin sa pwedeng sa may lower back, mga ganun, okay? And what you will see on histologically is large cells with increased glycogen sa rhabdomyoma and spider cells. Heart failure. So, sa patients na may heart failure, it could be left-sided or right-sided. Pag sabi left-sided heart failure, ang etiology is yung mga ischemic heart disease, hypertension, mga valvular diseases. And ang mahalaga malaman ninyo dito sa mga patients na may heart failure is nagkakaroon ng pulmonary congestion. Kasi di ba pag may left-sided heart failure, nagba-back up yung blood into the left atrium. From the left ventricle, babalik na left atrium, pabalik ng pulmonary vein, and then into the lungs. So what happens is, nagkakaroon ng pulmonary congestion and edema, pulmonary edema. So dahil bumabalik doon, nagkakaroon din ng blood into the alveoli. So nagiging hemosiderin-laden yung mga macrophages na nandun sa alveoli. So leading to hemosiderin-laden macrophages known as heart failure cells. Sa right-sided heart failure, the most common cause is left-sided heart failure, not cor pulmonale, which is right-sided heart failure from a pulmonary disease. For example, COPD, diba? So, yun yung mga nagkakos ng cor pulmonale. But the most common cause of right-sided heart failure is left-sided heart failure. Okay? So, mahalaga malaman ninyo dito sa right-sided heart failure is dahil nagbaback up naman yung blood from the right side of the heart pabalik sa right atrium and then into the IVC. So, nagkakaroon ng congestion sa liver. So, yung tinatawag natin na nutmeg liver. Pag naman, what you will also see sa mga patients na congestive hepatomegaly is centrilobular necrosis. Yun yung tinatawag natin na cardiac cirrhosis. We will also see congestive splenomegaly and some effusions and peripheral dependent. Treatment for these patients, uh, uh, in patients with heart failure with reduced ejection fraction, so ito yung ang ejection fraction is less than equal to 40. Pag sinabi namang heart failure with mid-range ejection fraction, that's 41, 49%. Pag sinabi naman na heart failure with preserved ejection fraction, that's ejection fraction or EF of more than equal 50%. So in patients with HFrEF or heart failure with reduced ejection fraction, ang binibigyan natin gamot ay ACE inhibitors, beta blockers, and ARBs if for ACE-I intolerant. So yun yung mga nagkakaroon ng cough, no, na dahil dun sa ACE-I. So ACE-I intolerant ang tawag nila doon, and then ARB. And then, so that's 2, ACE-I ARBs, beta blockers. Number 3 is aldosterone antagonists. Now, hindi naman lahat ng patients na may heart failure ay binibigyan natin ng beta blockers. So, hindi yun binibigay sa mga patients may acute heart failure. Kasi yung mga patients may acute heart failure, sila yung may mga hypotension. So, pag nabigay ka ba ng beta blocker sa patient may hypotension less than 90 na SBP, you will push the patient to further hypotension, which will result to shock or cardiogenic shock. And then, sa mga patients naman na yung iba nating gamot is angiotensin antagonists. So, nagbibigay tayo ng ACEs or ARBs sa mga patients na may heart failure kasi they can decrease ventricular remodeling. So, sabihin, cardioprotective sila. Now, we also talk about digoxin. So, kailan ginagamit ng digoxin? Kasi ito yung mga first line natin. So, kailan natin binibigay ng digoxin? If you have a patient na hindi kaya magbigay ng beta blockers kasi hypotensive, acute heart failure, congested, yung may pulmonary congestion, kasi mababa yung LV contractility, pero mababa yung BP, so hindi ka pwedeng bigyan beta blockers. Dahil nga mababa yung BP, nagkaroon ng AKI, hyperkalemia, mataas ang potassium, hindi ka rin pwedeng magbigay ng ACEs or ARBs. So in those cases, you can give digoxin to increase the contractility of the heart. So ano ba yung mechanism of action ng digoxin? Bakit siya nakakapagpa-increase yung contractility? Dahil sa direct inhibition of the sodium-potassium ATPase. So normally kasi ang ginagawa ng sodium-potassium ATPase, naglalabas siya ng tatlong sodium tsaka 2 potassium naman ang pinapasok niya. Okay? And paglabas ng tatlong sodium na yon, dahil marami ng sodium extracellularly, okay, dahil sa sodium-potassium ATPase, pupunta yung sodium kung saan yung kanyang from higher concentration to lower concentration. So, ang lower concentration niya is intracellularly. So, from outside, yung sodium, papasok siya through this, itong orange na transporter na to. And pagpasok ng sodium dyan, papunta sa loob ng cells, may lalabas na calcium. So, ang tawag doon is sodium-calcium exchanger. Okay? But, ang ginagawa ng digoxin, is to inhibit sodium-potassium ATPase. So, pag in-inhibit yan ni digoxin, so, imbes na yung sodium ay lumabas, may ipon yung sodium sa loob ng cells. Okay? So, pag naipon yung sodium dito, okay? So, they will try to find a way out. So, sobrang daming sodium dito, di ba? So, lalabas yan dyan. So, pag lumabas yung sodium dyan, maraming calcium ang papasok. And pag maraming calcium ang pumasok, tataas yung intracellular calcium, more calcium available for muscle contraction, mag-i-increase yung cardiac contractility. Okay? So, ang mahalaga maalala nyo dito sa digoxin is kailangan nyo i-monitor yung serum electrolytes, particularly potassium. Kasi hypokalemia can predispose to toxicity. So, bakit kaya magkakaroon ng gano'n? Kasi dito yung sodium-potassium ATPase, meron yung binding sites for potassium. Now, kung masyadong mababa yung potassium mo dahil may hypokalemia ka nga, yung digoxin ang papalit dun sa potassium binding site ng sodium-potassium ATPase. Ibig sabihin, mas maraming digoxin ang pwedeng kumabit sa sodium-potassium ATPase Kasi nga, wala namang naka-position doon na potassium dahil nga may hypokalemia ka. So, magkakaroon ng digoxin toxicity. Ang tawag ay permissive digoxin binding at the potassium binding site of the sodium-potassium ATPase. Okay? Now, pag nagkaroon ng digoxin toxicity, how do we resolve it? We give the antidote na anti-digoxin Fab fragments. Pero kung yung patient naman ay mababa lang naman yung potassium kaya sa nagkaroon ng digoxin toxicity, you can just slowly normalize the potassium. Okay? Next is rheumatic heart disease. So the most commonly involved valve is the mitral valve. Second most commonly involved is aortic, tricuspid, and then pulmonary. So yung buzz phrase dito sa rheumatic heart disease is fish mouth deformity. Sa rheumatic heart disease din, you can see verrucae. Ito ay mga vegetations overlying the necrotic foci along the lines of closure. So, yun yung buzz phrase sa rheumatic heart disease. Kailangan yung tandaan yan. And then, meron din tayong presence of McCallum plaques na makikita nyo sa subendocardium described as irregular thickenings. Okay? Usually in the left atrium. Now, we go to infective endocarditis. So this is microbial infection of heart valves and neural endocardium. Now, the hallmark of infective endocarditis is vegetations. Okay? Meron tayong dalawang type. We have acute and subacute. Acute is commonly caused by Staph aureus, and subacute is commonly caused by less virulent organisms such as viridans, strep, and Hasek organisms. Ang valves na inaapektuhan na acute IE is previously healthy and ang subacute naman is previously diseased, so more pronounced yung tissue destruction sa acute IE and less naman sa subacute. Now, ang mga kailangan ninyong tandaan sa microbiology ng IE is that tricuspid valve endocarditis is associated with IV drug use. Okay? So, pag ang patient ay may IE, ang ina-involve ay tricuspid valve, kasi di ba most commonly involved naman sa IE is yung aortic tsaka yung mitral valve. Less commonly in tricuspid valve. Now, pag ang patient nag-present with tricuspid valve endocarditis, you have to investigate kung meron siyang IV drug use. Okay? So, para matandaan niyo, ito yung ating mnemonic. Don't try drugs. Don't try drugs, tricuspid, and drugs. Okay? So, para mas ma-associate niyo siya. So, itong slides na to, itong content na to is from, First Aid for the USMLE Step 1. Okay? Magandang book yun. So, ang mga microorganisms na associated with tricuspid valve endocarditis ay Staph aureus, Pseudomonas, and Candida. Now, if a patient naman, sa questions din, for example, sa board exam, may infective endocarditis yung patient, tapos may nakita kayong siya yung patient is may colon cancer, yung most likely na tutubo dyan is sa kanyang blood culture is strep bovis or previously known as strep galolyticus. Now, yung patient naman is may prosthetic valves, yung most commonly tutubo sa kanilang blood culture kung sila may infective endocarditis is Staph epidermidis. But if the culture if the blood is culture negative, the most likely organisms are Coxiella burnetii and Bartonella. Ang morphology ng patients na may infective endocarditis ay yung mga, sinabi nga natin, di ba yung hallmark is yung vegetation? So what you will see is friable, bulky, potentially destructive lesions. Ang laman ng mga vegetations na yun ay tatlo: fibrin, inflammatory cells, and bacteria. Okay? Which can later embolize to become septic embolus. Okay, ito yung sinabi natin kanina, yung right valves ay sa mga IV drug users, most commonly affected ay aortic and mitral. Okay? Now, dahil meron tayong mga infected vegetations known as infective endocarditis, meron din tayong mga vegetations na non-infected naman. So, ito yung itsura ng vegetation sa IE. Ito yung itsura ng vegetation sa rheumatic heart disease. Di ba ito yung tinatawag natin na verrucae kanina? As you can see here, verrucae ay mga small vegetations along the lines of closure. Tingnan niyo. Ayan, along the lines of closure. Yung sa RHD, di ba? Tapos meron din tayo mga vegetations na non-infected tulad ng NBTE tsaka LSC. So pag sinabing NBTE, that's non-bacterial thrombotic endocarditis. So ito yon. tinatawag din natin na marantic endocarditis. And we also have LSE, or Liebman-Sachs endocarditis. So, pag sinabing marantic endocarditis, it happens in patients with um, it happens in patients with with hypercoagulable states, and ito ay mga sterile thrombi, meaning wala silang bacteria. Okay? Okay? So, pag ganon, walang invasion or inflammation. So, ano yung mga hypercoagulable states? For example, in a patient with cancer, no, may hypercoagulable state sila. So, pwedeng magkaroon ng marantic endocarditis in patients with cancer. Next is Liebman-Sachs endocarditis. Madali naman itong tandaan. Di ba ang Liebman-Sachs endocarditis is LSE? Okay? So, it happens, ang LSE, it happens in patients with SLE. Okay? Yan. So, Liebman-Sachs endocarditis happens in patients with SLE. No? As you can see, yung description ng vegetations sa LSE ay sterile vegetations din, parang marantic endocarditis, walang infection, walang bacteria. So, sterile vegetations, tingnan nyo, either or both sides of the valve leaflets. Okay? Tingnan nyo, both sides, sa taas at sa baba ng valve leaflets. So, ganon yung description ng Liebman-Sachs endocarditis. Either or both sides of the valve leaflets. So, yung paano nyo tatandaan? Paano nyo tatandaan na both sides of the valve leaflets ang Liebman-Sachs endocarditis? Di ba ang Liebman-Sachs, dalawa yung apelyido, Liebman tsaka Sachs. So, dapat ay dalawa rin ang sides na affected sa Liebman-Sachs endocarditis. Both sides, taas at baba. Both sides, dalawa sides ang affected sa valve leaflets, dalawa rin ang apelyido, Liebman-Sachs endocarditis. Next is rheumatic fever. So, rheumatic fever naman is acute immunologically mediated disease occurring a few weeks after an episode of gas infection or group A streptococcal infection. Okay? Yung pathophysiology centers on the phenomenon of molecular mimicry. Ang sequelae nito is RHD. So, sa morphology ng patients na may rheumatic fever, what we will see is Ashkoff bodies and Anichkow cells. So, tandaan niyo magkaiba sila, no? So, pag sabi Anichkow cells, activated plump macrophages and may caterpillar cells. So, tatandaan niyo magkaiba sila. So, paano niyo tatandaan yun? Pag sinabi Anichkow cells, mas marami yung letters niya, di ba? Mas marami yung letters, so parang mas mukha siyang mataba. So, plump. Activated plump macrophages. So, plump, mas marami, mas mataba kasi mas maraming letters. And tandaan niyo yung mataba na yon, na macrophages, no? Imagine nyo na may mataba ka rin, may pet kang caterpillar na mataba. Okay? So, yung caterpillar cells mo ay naalaga, ay plump din. So, Anichkow cells sila. Ganun lang yung association na isipin niyo. Para hindi ninyo malimutan na yung Anichkow cells ay different from Ashkoff bodies. So, sa rheumatic fever, hindi masasabi natin, consequence siya of pharyngeal infection with GAB-HS or Group A, beta hemolytic streptococci. So, ano ba ibig sabihin ng beta hemolytic? Okay? Kung sinabi beta hemolytic, we have to differentiate that from alpha hemolytic. So, pag sabing alpha hemolytic, parehas naman silang gram-positive cocci, pero ang alpha hemolytic ay partial oxidation of hemoglobin, causing greenish or brownish color without clearing around the growth ng blood agar. So, examples ng mga alpha hemolytic ay strep pneumoniae and viridans strep. So, makikita nyo dyan, no? Hindi siya masyadong clear, di ba? Medyo greenish and brownish pa siya, di ba? Yung clearing niya around the growth ng alpha hemolytic bacteria. As opposed sa beta hemolytic bacteria, gram-positive din, pero dito is, di ba dito is partial oxidation, dito is complete. Beta hemolytic is complete lysis of RBCs. So, pale and clear na yung area surrounding the colony and the blood agar. So, you can see here, malinaw na may clear area, no? So, mga examples ng mga beta hemolytic bacteria is Staph aureus, Strep pyogenes, or Group A strep, saka Strep agalactiae, or yung Group B strep. So, yung ating rheumatic fever is commonly caused by GAB-HS or Group A beta hemolytic streptococci or yung Strep pyogenes. Yun yung common cause ng rheumatic fever. Okay? So, for the last topic, we have syphilitic heart disease. So, it occurs in tertiary syphilis. Ang buzz phrase naman na kailangan yung tandaan dito is meron niyang aortitis, which is described as obliterative endarteritis of vasa vasorum of the proximal aorta. So, dyan mo lang mababasa yan, yung obliterative endarteritis of vasa vasorum. So, makikita mo yan talaga sa syphilitic heart disease. No? Sa tertiary syphilis lang pati siya makikita, hindi sa primary or sa secondary. Hindi. Tertiary syphilis lang. So, meron dito ang description na 3-bark appearance of the aorta. Okay? So, treatment for syphilis is PENG. Okay? So, the mechanism of action is to binding to penicillin binding proteins. It inhibits transpeptidation and bacterial cell walls. Now, ang unique sa treatment ng syphilis, pag binigyan mo sila ng PENG, they can experience, yung mga patients na binigyan mo ng PENG, they can experience a syndrome of fever, chills, headache, myalgia following antibiotic treatments for syphilis. Okay? So, ang tawag dun sa reaction na yun is Jarisch-Herxheimer reaction. So, if you give penicillin in patients with syphilis, you can experience Jarisch-Herxheimer reaction na ganito yung symptoms. So, ang reason behind that is due to the host response to the sudden release of bacterial antigens. Kasi, pag nagbigay ka ng penicillin, mabilis mamamatay yung mga treponema pallidum. And pag namatay yung mga treponema pallidum, maraming bacterial antigens na pupunta sa bloodstream, and yung host response to those bacterial antigens, that is what will produce the Jarisch-Herxheimer reaction. Okay? So, hindi siya allergic reaction. Okay? So, dahil siya sa host response to the sudden release of bacterial antigens. Tandaan niyo yung mechanism na yan, no? Kasi tinanong na yan sa PLE last year, 2021, kung ano yung mechanism ng Jarisch-Herxheimer. Okay? So, that's the end of my lecture. I hope na magagamit niyo siya sa mga susunod ninyong rotations and in your early preparation for the PLE. Okay? So, see you next time.